Okay, so I'd like to welcome our colleague. I think I heard that 600 registered online and 80 physically will be with us. So we're going to start our first session, which will be on new HF guidelines, diagnostic and treatment algorithm. And it's my pleasure to have my colleague, Dr. Matlooba Al Zadjali. Unfortunately, she's not with us here, but with us virtually. She's consultant cardiologist and heart failure, highly experienced in this field and highly educated. She will talk to us about diagnostic algorithm for heart failure.
Right. In the coming 10 minutes, I will be discussing about diagnostic algorithm for heart failure, basically in 2021. There are principles for diagnosis of heart failure. So we have steps, which is very much important when you come to diagnose heart failure patients. You need to consider medical history, sign and symptoms. For confirmation of diagnosis, you need natriuretic peptide and echocardiography. And for clinical phenotyping, HFrEF versus HFpEF, and then to assess etiology either by angiography, cardiac MRI, or biopsy, risk stratification, and workup for targeted therapies. So there are stage process for diagnosis of heart failure. We have stage A, B, and C. For stage A, we need to do risk assessment at pre-clinical stage as well as initial diagnostic workup in symptomatic patients. So here we need to do for the clinical assessment and comorbidities. We have to take history, physical examination, sign and symptoms, and then we need to conduct some biomarkers, specifically cardiac biomarkers, and also echocardiography and stress test. For stage B process, you need to go into detailed workup in case of heart failure, specifically when you are unsuspect or dealing with an uncertainty for the diagnosis of heart failure. So here, you need to conduct stress echocardiography and do some basic testing, cardiac MRI, and also other investigations to rule out other comorbidities. Whereas for stage C process, underlining the pathophysiology and the etiology for the heart failure, so here you need to conduct cardiac MRI, biopsy, and scintigraphy. So this is very important to rule out the cause of heart failure, whether it is related to cardiac amyloidosis or not. So what are the particular relevance for the pro-natriuretic peptide or natriuretic peptide in general in heart failure patients? It's very important actually for the diagnosis of heart failure, staging of the heart failure, risk stratification, and also it is important for monitoring and up titration of the treatment. And also it's important in admission and discharge decisions to rule out symptomatic LV dysfunction. So the following are the diagnostic tests which are recommended for the assessment of patients who suspect of chronic heart failure. We have BNP, NT-proBNP, which is recommended as per the new guideline of the European Society of Cardiology as a class 1 and level of evidence B. ECG is also important when you are suspecting patients with heart failure to rule out any causes of arrhythmias, and also echocardiography to confirm the diagnosis and to assess the ejection fraction. Chest X-ray is important as well to rule out pulmonary edema, and there is some routine blood test, for example, to exclude other comorbidities. You need to conduct like full blood count, urea electrolyte, thyroid function test, lipid profile, glycated hemoglobin. So all these are recommended as per the new guideline as a class 1 and level of evidence C. So this is actually the algorithm when you're dealing with heart failure patient or suspect of chronic heart failure patients. So you need to look for the risk factors, take patient's history and physical examination. You have to dig into their sign and symptoms, and then conduct ECG. If the ECG is abnormal, then you have to consider NT-proBNP or BNP. If the NT-proBNP and BNP above the cut point level as per the guideline, then you need to consider echocardiography for confirmation of the diagnosis. And then if the echocardiography shows that there is heart failure or suspect of chronic heart failure, or the diagnosis is confirmed, then you need to define the heart failure phenotyping based on the LV ejection fraction measurement. either it is HFrEF, HFmERV, or HFpEF. Then you have to determine the etiology of chronic heart failure and commence the treatment. If, for example, the NT-proBNP or the BNP is below the cut point level as per the guideline recommendation, then the heart failure, it is unlikely, then you need to consider other diagnosis for patient symptoms and signs of suspected heart failure. Whereas for the acute onset of heart failure, here the story is quite different. So, so what you have to do in the emergency room, of course, you need to be very quick, take patient's history and dig into the signs and symptoms. Then you need to conduct ECG, pulse oximetry, echocardiography, your routine lab investigations. Also, it's very important to conduct chest X-ray to rule out pulmonary edema, lung ultrasound if it is available in the emergency room. Then you need to conduct the natriuretic peptide testing, and here the NT-proBNP or BNP or proBNP, the cut point level is quite different compared to the chronic heart failure as per the new guideline. If it is above the cut point level, then acute heart failure is confirmed. Then you need to do comprehensive echocardiography to reach into the diagnosis. If, for example, the cardiac biomarkers like NT-proBNP or proNP or BNP is below the cut point level for acute heart failure, then the acute heart failure, of course, it's ruled out. So here is the recommendation of the investigations as per the guideline in 2021. We have the cardiac MRI. It is recommended as a class 1 and level of evidence C in patients with heart failure or for the assessment of the myocardial structure and function in those who have poor echo window. And also it is recommended in patients with suspect of infiltrative cardiac diseases. And also cardiac MRI, it is recommended as per the guideline to distinguish between ischemia and non-ischemia myocardial damages, and it is considered to be as a class 2A with level evidence C. So what's about the invasive coronary angiography? Invasive coronary angiography, it is considered as a class 1 and level of evidence B in patients with symptoms of angina and ventricular arrhythmia despite patient being on medical therapy. And also it is considered as per the guideline in HFrEF patients with intermediate to high pretest probability of coronary artery disease and presence of ischemia in non-invasive stress testing as a class 2B and level of evidence B. So what's about non-invasive testing? Also non-invasive testing, it is recommended by the guideline. For example, CT angiography considered to be in patients with heart failure, low to intermediate pretest probability of coronary artery disease as a class 2A and level of evidence C. And also it is considered for assessment of myocardial ischemia and viability of patients with coronary artery disease who is suitable for cardiac revascularization as a class 2B and level of evidence B. And also it is important or considered to detect reversible myocardial ischemia in patients who has symptoms or cause of dyspnea as a class 2B and level of evidence C. Cardiopulmonary exercise testing is considered to be as a class 1 and level of evidence C in patients for evaluation of heart transplantation. And also it is recommended as per the guideline or considered in heart failure patient to optimize prescription of exercise training and also to identify the cause of unexplained dyspnea or exercise intolerance. And it is recommended as per the guideline class 2A and level of evidence C. What's about right heart catheterization? Right heart catheterization, it is considered as a class 1 by the new guideline and level of evidence C in patients with severe heart failure being evaluated for the heart transplantation. So this table actually, I'm sorry, first of all, it's very hazy. It's actually distinguished between the recommendation for diagnosis of heart failure in 2020 compared to 2016. So what's new in 2020 for diagnosis of heart failure? So we come for the invasive coronary angiography, which is a step down to class 2B for the patients with HFrEF in intermediate to high pretest probability of coronary artery disease and the presence of ischemia in non-invasive stress testing, whereas it was in 2016 as a class 2A. Non-invasive testing, CT angiography, it's stepped up actually in 2021 as a class 2A. Recommendation: heart failure patients with low to intermediate pretest probability of coronary artery disease to rule out coronary artery stenosis, whereas it was in 2016 as a class 2B. Right heart catheterization, it is actually stepped down to class 2B. Recommendation as per the new guideline 2021 to rule out the pulmonary hypertension in patients with symptoms of heart failure, where it was in 2016 as a class 2A. And thank you very much.
Thank you very much, Matlooba. As usual, you know, you're nice taking the hard part always. Any question from, I mean, we have Dr. Fadal. Be quick.
You have mentioned while you're in the presentation biopsy, but I don't find any place in the biopsy for the, or through the guidelines of European. And your introduction, you said biopsy. So when you expect that biopsy is needed? Because I didn't see it at all in the guidelines.
Did you hear the question, Doctora? Can we, you are not hearing Dr. Matlooba.
She's muted.
Should I repeat again?
Yeah, can you hear me now?
Yes, yes.
Right, okay. So, of course, cardiac biopsy, it's not mentioned in the algorithm of the guideline, but I mentioned earlier, I mean, in my first slide, that it's very important to have cardiac biopsy in order to know the underlying pathophysiology and etiology of diagnosis of heart failure. So as I mentioned, that there is a staged process in order to diagnose heart failure. So it's not only to concentrate, I mean, on, you need to concentrate on certain things in order to reach to the diagnosis. So as I mentioned, for the risk assessment, preclinical stage, there are certain things you need to do. And also for your initial workup, there are certain investigations you need to do for detailed workup of the case and certainty to know the comorbidities. So, and the cause of heart failure or etiology of heart failure, then here you need to do certain things. Whereas for the pathophysiology, cardiac biopsy is important, but of course it's not mentioned in the algorithm.
If you want,
Marco,
yes,
Marco.
if you want me to add
Yes, please.
something, I was looking for the slides, but it's the same. Biopsy is included as a class 2A recommendation, both among the diagnostic procedures of the guidelines, and then when in the chapter about cardiomyopathy and myocarditis. The concept is that it is recommended when there is a clinical deterioration despite optimal medical treatment of the patients, and it is recommended also when we suspect a treatable cause of heart failure, such as sarcoidosis or gigantocellular myocarditis or eosinophilic myocarditis in these cases. So when there are specific cases of myocarditis where immunosuppression may be indicated, it's indicated. Not in everybody, yeah.
As an intervention cardiologist, I see the coronary angiography used to be, as you said, 2A, went to 2B. From a research point of view, how you achieve that? Why you went from 2A to 2B?
Well, I mean, it is, I didn't get your question in the research point of view.
I mean, to get a 2A, you know, you either to have a randomized clinical trial or a big observational study, but, you know, what made the guidelines people to downgrade it?
Well, again, depend on the clinical trials that they conducted. Accordingly, they stepped down to 2B, so that we have level of evidence, which is the classes, and then we have the level evidence itself, like A, B, C. So for the classes recommendations, so it was class 2A, now we stepped down to 2B, but again, it's based on the clinical trials or based on the systematic review that which was maybe conducted, and it had been shown that it is, I mean, it went a step down rather than it was in 2016 in class 2A. So the hierarchy of the level of evidence.
Thank you very much for this first introduction on the diagnosis of heart failure.